I'm one of the pharmacists here at Healthy Choice Compounding Pharmacy, and tonight we're very happy and proud to have Dr. Elizabeth Poynor, who's going to be discussing some testosterone for you, both men and women applications. Next slide there, Corinne. And I'll just give a brief explanation about what we are about, who we are, what we do. We started compounding back in 1997 when we had to explain what compounding was. Today, it's become part of, not mainstream, but most people do understand what we do. It's about personalized medicine, making medicine to fit the person. If you have allergies or sensitivities or customized doses. And I really feel that in the world that we are in now and how we're moving forward, genetic testing and personalized medicine is going to be the wave of now and of the future. About 5 years ago, we had moved from a hybrid retail compounding location to a state-of-the-art compounding facility. So we followed our passion, and this is the only thing that we do now. And our main thing is we're dedicated to what we do. To provide, and this is one of the things that we're dedicated to, provide cutting edge information. Dr. Poynor is world renowned in what she does, because the more you're educated, the more you understand the process, the more successful you're going to be. We're here to educate our patients about the process, real life expectations of what their medication is going to be and what their potential outcomes we can do. And we also create different types of medications. Are you sensitive to a lozenge? Do you need a topical? Do you need a rectal application? It's really about creating what you need to help your personal health. And Dr. Poynor is great like this. We've worked with Dr. Poynor over the years, coming up with different formulations. She had a personal lubricant that was no longer imported from England, so she asked us to create it, and we created it for her. That's what we do. It's fun, it's exciting. We're always doing different types of things. Some of the ways that we do this is through bioidentical hormone, men's and women's health, customized thyroid replacement. I think a huge component is autoimmune issues, and they say over 25% of the population has some sort of autoimmune disease, and that's where low-dose naltrexone comes in. Pain management ties in with low-dose naltrexone, and later this month we're going to have Dr. Barry Erner talking about chronic pain and using different modalities to treat that. Dermatology, people have so many different sensitivities topically, and we can make different formulations, different bases to help them. And this is who we are. This is our lab. This is where we create all of our medications. If you have any questions, you can ask us tonight. You can email us. You can call us. You can even text us to this phone number. And at this point, I don't want to waste any more time because I know Dr. Poynor's time is very important. I'm going to turn it over to Dr. Elizabeth Poynor. Dr. Poynor, take over, please.
Thank you, Phil. I'm going to try to share my screen here and hopefully get the right slides up. So there we go. It worked. So Phil, thank you very much for allowing me to speak tonight on one of my favorite topics, modern hormone support and testosterone therapies. And I'm going to take you on a little tour tonight through the endocrine system, mainly in women, because I'm actually a gynecologist. When we talked about endocrinology in women, we really talked about the thyroid, the adrenal glands, and the ovaries. We still talk about the thyroid, the adrenal glands, and the ovaries, but in the past, you were either hyperthyroid or hypothyroid, and we measured your TSH and your T4. With your adrenal glands, you either had good cortisol or not, and you either had Addison's disease or not, or something else that wasn't diagnosed. And in the ovaries, when we looked at the ovaries in the past, we looked at, were you menopausal, yes or no? Was your FSH elevated? And what was your estradiol level? And thankfully now, we look at these structures and the hormones that they secrete in much more detail, and we look at the nuanced interplays between them. And the thyroid now, and I call this present future because these are more modern thoughts, more integrative thoughts, the intersection between more allopathic medicine and integrative medicine. And we now look at more sensitive thyroid testing. We look at anti-thyroid antibodies. Do you have Hashimoto's, yes or no? And also now we pay attention more to symptoms. Do you have symptoms of hypothyroidism? What are your numbers? We don't just look at the numbers alone with the TSH and the T4. We look at these in a little bit more detail. With the adrenal glands, we also now look at more subtle changes in the adrenal glands. So we're not looking at just your cortisol and your 24-hour urine cortisol. Do you have Addison's, yes or no? We're looking at your secretion of cortisol over time throughout the day. And we're looking at, are your adrenal glands functioning for you in your modern life? And that's so-called adrenal fatigue, actually. And again, really that intersection between allopathic and integrative medicine, the more subtle nuances of the adrenal glands and the hormones that they secrete are a little bit more integrative in the way people look at them. However, it's gaining a little traction in the allopathic world. The ovaries, we're now realizing that they produce more than estradiol. We've always known that the ovaries have produced progesterone, but we also now realize that the ovaries produce a significant amount of testosterone and other androgens such as DHEA, which are meaningful for women, which in the past had been trivialized. And we're also now realizing that menopause is more than hot flashes. It used to be that we would ask women, are you having hot flashes, yes or no? And if the answer was no, well, you're fine, your menopause is fine, don't worry about it. And we've gone far beyond that now in how we look at menopause. Thankfully, we're now, the more modern thoughts with the interplay of the endocrine system really looks at that triad, are those three legs of the stool of the thyroid, which is the master regulator of metabolism. So the thyroid secretes T4, which was the major thyroid hormone, which is also converted into T3. The adrenal glands secrete not only cortisol, but they secrete mineral corticoids, but also importantly, DHEA and DHEA sulfate, and that's very important for women. And the ovaries now also, we now realize that they produce a significant amount of androgens for women. And we also know now that there's an interplay between the thyroid, the ovaries, and the adrenals. And for example, if the adrenals are working overtime, they're going to pull progesterone away, and women may become somewhat progesterone deficient. If women have replaced with estrogen, either through birth control pills or through hormone replacement therapy, that will also impact the thyroid hormone. So we now know that we don't just check FSH and estradiol in isolation and treat women in isolation with estrogen if they need it, but we need to look at this overall interplay between the thyroid, adrenal glands, and ovaries. So the ovaries are my favorite structure, that they are two almond-shaped, walnut-sized organs that lie deep in the pelvis, just lateral on either side of the uterus. They produce estrogen and progesterone each month, which leads to a woman's monthly menstrual cycle. And when the ovaries stop functioning at the time of menopause or taper off in functioning at the time of perimenopause, the ovaries cease to produce progesterone because we're not ovulating anymore and produce estrogen alone at declining levels. And therefore, a woman will lose her period and become what we call menopausal. In the triad of endocrinology in women are the adrenal glands, and we're going to focus on the adrenal glands tonight a little bit with the androgen production. These are two, again, walnut-sized, basically, structures that lie deep in the back, just above the kidneys, actually, producing, again, cortisol and also a number of androgenic type hormones. The androgens that are in women, that we usually think that androgens are for men only and are important in men only. However, in women, androgens are important because we actually have androgen receptors in our bodies, but also some of these androgens are actually peripherally converted into estrogens. And so they're prohormones for estrogens. And the androgens are quite important in women. The androgens that we'll speak about in women are DHEA sulfate, which is largely from the adrenal gland, DHEA, which is from the adrenal gland and the ovary, androstenedione, testosterone, and DHT, and these are in declining presence at serum levels in women. So when I do a lot of surgery, unfortunately, I do a lot of oophorectomies where I take out ovaries, and for prophylactic reasons. And when I used to counsel women, it would be, you'll just lose estrogen, you're not going to lose anything else, you're just going to lose estrogen. And then I heard stories with, I've been doing this for a long time, 30 years ago, women say, but I don't have, the same libido, the same sex drive after my ovaries are out. And I say, no, that's just that's just probably your estrogen. And we would say that a very small portion of that androgen pie, or the amount of androgens in the women's body, actually comes from the ovaries. The majority are from the adrenal glands. That was completely false. About half of the androgens in a woman's body actually come from her ovaries, and half come from the adrenal glands. And in a premenopausal woman. In a postmenopausal woman, these androgens actually taper off through age, and there's a larger portion of that androgen pie that actually comes from the adrenal glands and less from the ovaries. But still, important components as a woman ages actually come from the ovaries. So to understand the functions of androgens or testosterone in a woman's body, you've got to understand the function of estrogens, because these hormones don't occur and act in isolation. So the function of estrogens, which are considered the major female hormone, are responsible for the monthly preparation of the uterus for pregnancy or for the menstrual cycle. They're important for breast with breastfeeding and growth of breast tissue. Very important in the brain for temperature regulation, or hot flashes, of which we refer to disordered temperature regulation in women, but also very important for libido and cognition. And now there's an increasing recognition of the importance of estrogens for cognitive function in women. And we now know that there's estrogen receptors throughout the brain and other parts of the body, in addition to the heart. Estrogen protects the heart against cardiac disease. In the liver, estrogen affects cholesterol metabolism. Higher estrogen levels are associated with better cholesterol, higher HDLs and lower LDLs, which is the bad cholesterol. In bones, higher levels of estrogen are associated with better bone density and better bone strength. And skin, estrogens actually have anti-aging effects. The function of progesterone is another area of more modern hormone replacement, which needs further studies. Again, in the past, it was really always considered that you don't need progesterone and hormone replacement therapy unless you have a uterus to protect against endometrial cancer. But we're now realizing that progesterone probably has other important effects in the body. It has metabolic effects and can affect fat metabolism and carbohydrate metabolism. Progesterone increases your basal insulin levels and increases the insulin response to glucose. So less progesterone, more insulin resistant, and also decreases sodium reabsorption. So it can be a little bit of have a diuretic effect. In bone health, progesterone has been noted to stimulate osteoblastic mediated bone formation, so bone building. It can improve skin elasticity. It's associated with important mood factors. So progesterone, when we replace progesterone, can lead to some somnolence and peace and tranquility in women. It may also have neuroprotective effects, and also may have important effects in immunomodulation. So the importance of progesterone actually goes far beyond just its function in the monthly menstrual cycle in protecting the uterus against developing endometrial cancer in hormone replacement therapy. Just like progesterone is not super well studied in women, androgens are really less studied in women. It was only recently that I think that we've realized that testosterone and DHEA are important in women. Androgens are, of course, precursors to other important hormones in women, especially estrogens. There are what we call aromatases in peripheral tissues, are the fat tissues or subcutaneous tissues, which convert androgens into estrogens. They're important for bone strength, most likely. Better androgen levels lead to better bones, and are very important in mood and libido. And we'll talk about this in just a moment, but androgens have typically been associated with, higher androgen levels have typically been associated with better libido and better mood. And I call that mood a better joie de vivre. We'll talk about that, like I said, again in a moment. The effects of testosterone in women, again, have been poorly studied. Actually, there are a few like large scale studies that have looked at this, but most have been looked with anabolic steroids in women, so synthetic androgen type hormones in women. But typically, androgens and testosterone can lead to an increase in lean body mass, an improvement in bone health. People with higher androgen levels or higher testosterone levels tend to have improved bone health and stronger bones. With cardiovascular health, we've always really thought that actually higher testosterone levels led to poorer cardiovascular health. However, there are some studies that show that higher androgen levels actually are associated with better cardiovascular health. So there's possible improvement in cardiovascular health with androgen, higher levels of androgens and supplementation. In breast health, the interactions are very complex. Androgens or testosterone tend to have an anti-proliferative effect in the breast, so they halt cell growth in the breast. However, the breast is rich in these enzymes called aromatases, which actually convert androgens into estrogens, so that there may be some elevated risk of breast issues with testosterone. Important to know that it's not that an estrogen-dependent malignancy is a contraindication to testosterone or androgen replacement. However, if you don't have a history, that the action on the breast may not be as bad as we may perceive it to be. In uterine health, there are aromatases that are in the uterus, so certainly testosterone can have a pro-estrogenic activity in the uterus because of these aromatases, and any abnormal bleeding in a woman who is using testosterone replacement therapy should be thoroughly investigated. With libido, which has the most data behind it with testosterone, it's mixed and complex. And a woman's sexual response is mixed and complex. So I think that the data is always going to be mixed and complex. There are certainly a subset of women who actually may benefit from androgen replacement therapy. And there are some who, because libido is a function of not only physiologic processes and how hormones work, but also psychologic processes. So a hormone may not be enough to overcome a psychologic issue with libido. However, it may offer some support. So these studies are difficult to perform, difficult to interpret. But however, androgens certainly for many women may actually help their libido. Causes of low testosterone in women are, of course, age-related. As we age, androgen production declines both from the ovaries and the adrenal glands. So DHEA, DHEA sulfate, and testosterone can go down. Hyperthyroidism can lead to lower levels of androgens, and exogenous estrogen administration or estrogen replacement therapy can lead to lower levels of androgens in a woman's body. So this is always an interplay when we do hormone replacement therapy for women. We always have to look at androgens also, I think. Symptoms of testosterone depletion will be diminished well-being, a lack of joie de vivre, fatigue, not having the same energy level, and of course, diminished sexual desire. So what are the risks of testosterone replacement in women? We're beginning to, in more modern hormone replacement for women, incorporate androgens such as DHEA and testosterone. Well, the risk that we're always concerned about are cancer. Are we increasing a woman's risk of developing breast cancer? Are we increasing her risk of developing uterine cancer or other estrogen-dependent or hormone-dependent type malignancies? There's no data to support that we increase the risk of breast cancer with testosterone replacement therapy. However, the studies are quite small and there there's not enough data to really comment on that. However, it doesn't seem to be that we increase her risk of developing breast cancer. Certainly, there are androgen receptors on breast cancer, so that if you have a diagnosed breast cancer, testosterone replacement therapy should not be your first mode of choice of treating symptoms, which may be associated with lower testosterone levels. Cardiovascular risk is, of course, always a concern. However, the data seems to support that you may have improved cardiovascular parameters with androgen replacement therapy. Of course, benefits include heightened libido, sense of well-being, and heightened energy level. Alternatives, there's not really a great alternative to testosterone other than testosterone. There's some herbs that individuals use that may help to increase testosterone levels that have been looked at, some kind of more natural remedies, but difficult to really get those testosterone levels up without testosterone. Major society recommendations, actually, and I look at this all the time, have really not recommended or not advocated for androgen replacement therapy, nor are there many large-scale studies ongoing with androgen replacement therapy. It's kind of the poor cousin to this in women. We really look at women as is only estradiol. And I think we're much more complex than that. And societies have really they've come out with pretty strong statements not to use testosterone replacement therapy unless you really have to. Obviously, it needs to be further studied. And it's really important to realize that there's no FDA approved therapy for androgen replacement therapy in women. There was a lot of talk about using androgens for women for libido. And again, libido is like the hardest thing to study because of its complex nature and the many reasons why a woman may have low libido. And it's not really reasonable to think that hormone replacement is going to affect all of these reasons for low libido. So the FDA did not approve androgen replacement therapy for women in libido, despite a number of studies showing that androgens can help with libido, not only testosterone, but also DHEA. So if a woman opts for testosterone replacement therapy, how can we do this? And this is where Phil's group comes in, and we always talk, and he helps me with this all the time. My favorite ways to replace are transdermal creams that are made by a compounding pharmacist, or a sublingual troche, which is just a small dissolvable tablet that goes underneath the tongue. Testosterone gels are available. They're not available for women, so you have to kind of guess and do a little pinch off of a man's gel, which is at a very high level, so we don't really usually recommend that. And there are testosterone patches, but there are no testosterone patches for women, and the patches are quite high, and you can start to cut them and such, but never advocate for that because the accuracy of that is really, really, really low. Sublingual, as we said, is troche is available. That gets a good gets a good level quickly for women. And I actually like troches for women who are having libido issues, because you can use a troche in the evening and actually have some stimulation of the genitals and feelings, and actually kind of heighten libido pretty quickly after using a troche. A cream gives you a more sustained level throughout the day, and may be better for a woman who's having energy issues, or maybe even cognitive issues with lower levels of testosterone. Oral testosterone is not preferred. There was an old preparation called Estratest, which contained conjugated estrogens and a oral testosterone. However, oral testosterones actually do impact the cardiovascular disease in an adverse fashion. That's been demonstrated, and actually may affect the liver. And so probably it's not the preferred way to replace testosterone. IM injections can be given on a monthly basis, and but require a trip to a physician or a healthcare provider, usually to do IM injections, and can be painful for many people. And testosterone pellets have gained some traction over the past number of years. But one of the issues with testosterone pellets is if a woman has a side effect or has a problem with testosterone, it's difficult to take them out, right? So if you don't feel well with testosterone replacement therapy, it's hard to take them out. And you also, with a pellet, get a very super physiologic level. And our goals with testosterone replacement are to really obtain a premenopausal level of testosterone. So I call it just a physiologic level of testosterone in women. And pellets don't do that. They give you this very high level that tapers off. Some of that is converted to estrogen, so you feel better also with the pellet, because you have these high levels of testosterone that are then converted into estrogen. So there are great benefits to some testosterone replacement in some women. Some women respond very well with energy, better thinking, better sleep, and we'll talk about that in just a moment. But there may be some side effects that women don't like with testosterone replacement therapy. But our lower dose transdermal preparations have a minimal risk associated with them, because remember, we're only replacing to physiologic levels, and if they're carefully monitored to avoid any of the superphysiologic dosing. Dose-dependent adverse effects of testosterone include hirsutism, so hair growth on the face or hair loss on the scalp oiliness or itching, androgenic alopecia, which is hair loss at the temporal regions and a bald patch in the back of the head, Behavioral changes such as anger or aggression can occur with some women who have super physiologic dosing of testosterone. Usually we don't see these types of behavioral changes with physiologic dosing. Deepening of the voice can occur, and this is really important if you're a vocalist or a performer. Important to realize that you can have some change in the voice with androgen replacement therapy. And clitoral megaly, which is an enlargement of the clitoris, can occur with androgen replacement therapy. Contraindications to testosterone replacement therapy, of course, or hormone-dependent malignancies. So breast cancer is the main one that we speak about. So why should I look at my testosterone levels? Why should I replace testosterone levels? Well, of course, low libido, fatigue, mood issues can be improved with testosterone therapy with or without estrogen replacement therapy if a woman is going through menopause or perimenopause, or even some of our younger patients have lower testosterone levels that may be improved by adding back some testosterone. And there's a little bit of talk now about PMS being associated with lower testosterone levels. This is something that I'm always looking at in the literature because a number of women who may have significant PMS may have also lower androgen levels. And then really the question remains, if you replace that a little bit, can some of that PMS be corrected? Individuals who have complaints of emotional lability, so a very short fuse, fatigue or loss of stamina, impaired concentration or memory. I have some of my patients who are, say to me, look, it took me so many years to get to the head of the boardroom, and now I'm not as sharp as I used to be. I'm at the head of the table in the boardroom, and we do a little bit of testosterone replacement therapy, and the mind is a little sharper, the memory is a little better. So that's something to think about. Again, no studies really looking at this, just all observational, and again, replacing to physiologic levels, not super physiologic levels. I've said libido 100 times in this talk because this is what is mainly associated and been looked at with testosterone. However, it goes far beyond that in women. Sleep disturbances can also be attributed to lower testosterone levels. Some women who undergo testosterone replacement may have better sleep, and of course, muscle weakness, which goes along with stamina and building of lean body mass. So how do we monitor if an individual comes to us and says, look, I want to try some testosterone replacement therapy? Well, we have very detailed counseling with our patients, reviewing that there are no FDA approved preparations. The studies are small. However, it seems to be that replacement to physiologic levels may be beneficial. We always check a baseline total and free testosterone level before initiating therapy. Testosterone levels should be checked every 3 to 6 weeks after starting therapy, and then every 6 months thereafter. And I would also use in this, you have to use a trusted compounding pharmacist, because remember, the drugs are only as good, or the effect of the drugs and safety of the drugs is only as good as the compounding pharmacist. And this is why I work really closely with Phil, and we have conversations about patients all the time. And it's super important actually with something like this. We need to closely monitor for the clinical signs of hyperandrogenism. So we look for any deepening of the voice, hair loss, any excessive hair growth we're looking for. So we want to have a constant dialogue about this. The goal is to maintain testosterone levels within a normal premenopausal range. So we don't want these super physiologic levels. We want just what would be normal for a normal premenopausal woman. And we always stop treatment if there's no clinical improvement after 6 months of consistent use, because we don't have data that shows us that bone building is better with testosterone in the absence of estrogen. And we don't have data that says that cardiovascular disease is better with the presence of testosterone in the long term with large scale studies. So that if we're not impacting a woman's symptoms of low testosterone, then we will go ahead and stop if she's not getting benefit from replacement therapy. So really important take-home points. There are no FDA-approved testosterone products which are currently available for women in the United States, so we need to use a compounding pharmacist. Long-term safety data of testosterone therapy is currently unavailable, but appears by small studies and that it is safe if dosed appropriately at physiologic levels. Testosterone therapy may take several weeks to be effective, so we don't just prescribe it and say come back in 2 weeks and stop. We give it time, and we stop if there's no improvement after 6 months. And we want to look at levels also as we dose as we dose testosterone. Frequent clinical laboratory and is monitoring and physical monitoring is required. The goals of therapy are to achieve clinical improvement while maintaining these physiologic levels. Additional studies are needed to demonstrate efficacy and safety of testosterone, and replacement benefits of testosterone, I think, are really under-recognized. I think this conversation needs to be had with more women. The levels need to be checked. There's a lot of controversy with checking levels because we're not checking tissue levels, we're only checking serum levels, but it's a surrogate marker for what may be a low testosterone in women. I always search the literature on a regular basis because we do converse about this with many of our patients, and if not all of our patients who are not well, if symptoms of menopause and perimenopause are not well controlled with our standard treatments, we really begin to delve more into testosterone. And there are some other outlets such as Mayo Clinic and some other very well-respected thought leaders in the country who are now coming out and saying that, look, we really need to have this conversation. The risk benefits and alternatives do need to be reviewed with women, but it's not unreasonable to begin to replace androgens in women. So we really need to begin to look at this in a larger scale and really consider this for many women. And that's where I'll stop.
Dr. Poynor, that was great. I picked up a couple points, and I think one of the things you said, we just are on the same page. You treat the patient, not the labs, and assessing the patient is so important. You just don't assess the labs, and the symphony of the hormones, how they all play together. Not everybody understands that. You're not just treating the thyroid, you're not just treating testosterone. It's a real symphony of how they all interact. So thank you.
Thanks for allowing me to speak.
Anytime.
All right, so it looks like we have some questions. Can you discuss how we can treat hair loss?
Phil, do you want to tackle that?
Hair loss is a little fun. Definitely check your levels, check your androgen levels. Hair loss is a multifaceted approach. Sometimes supplementation with biotin. We have done a progesterone, estrogen shampoo for some patients, which we've had good success with. And nutritionally, you said you have a nutritionist on staff. I think nutritionally, you have to look at what's going on in that person as well.
Yeah, I think nutrition, and I think one of the areas of hair loss that I'm actually interested in, that people are beginning to talk a little bit about. Look, the common ways to treat hair loss are to block the action of androgens at the level of the hair follicle, right? Using inhibitors of androgens on the hair follicle, because higher androgens equal more hair loss, right? Or there may be a sensitivity to androgens. So we use drugs such as finasteride, spironolactone, and these types of medications to block the action of androgens. But one of the areas that I'm actually really interested in is mitochondrial support and hair loss, actually. And there's a little bit published about on it, not a lot. But hair loss is, for some, is a disease of aging, right? And if you think of aging as a mitochondrial issue, we're beginning to look at mitochondrial issues in cancer prevention and treatment, cardiovascular disease, cognitive issues in mitochondria. And, as mice and laboratory mice age, they all get sarcopenic, or they lose their body mass and they lose their hair, right? And some of these agents which may affect mitochondria may actually help with hair. And that's an area that is getting a little bit of a play, not a lot yet, but getting some play. And so that's an area that I'm particularly interested in, because hair loss for women is 50% of women have experienced problems with hair loss as they age. So again, complex, tricky. For not all do the anti-androgen type drugs work, and so needs further exploration.
Great. Another question, can you discuss the effect of testosterone on cholesterol?
So, I was always until I really got involved in hormone replacement therapy over the past, 20 years, I always thought, oh, androgens, men have a higher risk of cardiac disease. than women, and women have a risk of cardiac disease when they go, that equals men when they go through menopause. So I said, it must be the androgens, right? So testosterone must be bad for your, or androgens must be bad for cardiovascular disease and lipids, right? But if you look at transdermal testosterone, again, not well studied in women, but there's some studies with transdermal testosterone, not oral testosterone, because remember, oral testosterone gets metabolized by the liver. So you swallow a pill, it goes into the, basically it's metabolized by the liver first, right? And then you get the metabolites and then you get the action of the drug. So if you have a transdermal medication or agent, it goes directly into the bloodstream via the skin, and you avoid what we call first pass metabolism, or you avoid that liver metabolism. So looking at the studies with transdermal testosterone, actually it can increase your HDL and decrease your LDL. So it gives you better good cholesterol and lower bad cholesterol, kind of the opposite of what you would assume. Again, not super well studied in women, and again, I'm focusing on women. I'm a gynecologist, and but oral testosterones and androgens actually can impact the cardiovascular system in an adverse fashion. And again, that's why we don't usually recommend oral testosterone. But it is interesting that the only medication that you can really buy at a CVS for women with testosterone, or CVS, or any commercial pharmacy, that can be any, I'm just referring to a commercial pharmacy, is a preparation that contains an oral testosterone, and we have to go to a compounding pharmacist to get a safer transdermal testosterone. So oral testosterone probably not good for the cardiovascular system, but transdermal probably okay. And then if you look at women who just have higher androgen levels throughout life, they actually don't necessarily have a higher risk of cardiac disease. But again, really small studies, and we need larger. It just brings home that we need larger studies, and we need to say, you know, it is, if testosterone really is helping women in menopause and perimenopause, well, then we really need to study the safety from the cancer standpoint and the cardiovascular standpoint.
Great. All right. Does anybody have any other questions? Feel free to raise your hand, write it in the chat box, Q&A.
No. Well, Dr. Poynor, I want to thank you for coming on and sharing all this great information. As always, I've always learned a little bit from listening to you as well. Your passion for what you do is evident, and your energy is just through the roof, and your expertise is right there with you. So I appreciate all of your support and all of your knowledge and helping all these women.
Thanks a lot. Appreciate it. Thanks for giving me the opportunity to talk.
And I want to thank everybody for joining us this evening. You'll receive a quick questionnaire. Any questions or comments, you can always reach out to us. Doesn't have to be through this chat or anything else. Our email is, you can reach me, Phil@HCCPRX. You can call or text us at our phone number at 914-238-1700. And then Corinne, what day is Dr. Erner going to be on?
The 23rd of February.
And we're going to have a Dr. Barry Erner talking about chronic pain on February 23rd. We'd like to see you there as well.
Also writing in the chat box, our website in case you wanted to check us out, and our info@email in case you had any other questions.
So thank you all for joining us. We hope to see you again towards the end of the month. And Dr. Poynor, thank you again for all of your great information and your time.